Hello, everyone. Hello, and welcome to aidsmapLIVE 8 2020 special. I'm thrilled to be joined by an incredible panel who will be discussing the most important stories to come out of the 23rd International AIDS Conference. I'd like to start off by bringing on the first guest, Dr. Laura Waters. Fingers crossed. Hi, Laura. How are you?
Good, thank you. Hi, everyone.
Hi. So, Laura, you're an HIV consultant at London's Mortimer Market Centre and chair of the British HIV Association. Is that right?
Indeed, yes, I am.
So, Laura, you were a guest on the first ever aidsmapLIVE, but this conference is a little bit different. I see on Twitter that you've been watching presentations from the bath. Is that right?
I have. So we are obviously in a new virtual world for conferences. It's tough. I miss the interaction, I miss the conversation, but I was able to lie in the bath watching a presentation on intramuscular HIV prevention. So, you know, there's always things to be had.
Wonderful. Thanks very much. Okay, so the next guest we're going to bring on is Lucy Wanjiku Njenga. Hi, Lucy.
Hi, Lucy. Hi, Susan.
How are you?
I'm very good, thank you.
It's absolutely thrilled to have you on. Lucy is the founder and team leader of Positive Young Women's Voices, founding coordinator of SOTI Skika, and active in the Athena network, What Women Want campaign. And you're also one of the plenary speakers of the conference. Yes. Is that right? So, Lucy, I know that you presented at the conference last year. How different has the experience been for you this year?
I thought the virtual world would be better, but it's been crazy. They're setting up only the recording part of that session. You don't want to know the drama that I went through. This virtual world is not doing good for me.
Well, fingers crossed we're going to get through this session. Thanks, Lucy. So the next guest I'm bringing on is Gus Cairns. Hi, Gus. I was like, oh, hi, Gus. How are you?
Hello. I'm fine, thank you. Very good. Yes.
Gus is my colleague at NAM aidsmap. You're one of the editors. You've been working in HIV for a gazillion years, pretty much. You're an expert on HIV prevention and PrEP. And you used to write for Positive Nation magazine. I think we worked together 18 years ago. 18 years ago.
Yeah, we did indeed. I remember you bringing your little baby in, and the next time I saw him, he was a grown man. So
yes, that's right. And so Gus, how's everything going for you and doing the conference virtually?
Well, it's fine because on one level it's better because you can sit back and kind of take your time to do the reports and you're not rushing from session to session and always thinking you're missing something. But on the other hand, like Laura, I really missed meeting the brilliant people you meet at the conferences and the conversations and the jokes and the laughs and all that sort of thing. So, you know, it's been okay, but I hope we get back to proper conferences.
Yes. Okay. Right. Thank you, Gus. And I'd like to bring on now Professor Linda-Gail Bekker. Hi, Linda.
Hi, Susan.
How are you doing
today?
Hi,
Susan.
Hey.
Good. Thank you.
Great. So, Linda, you're a physician, a scientist, and infectious diseases specialist. Is that right? Deputy Director of the Deputy Director of the Desmond Tutu HIV Centre at the University of Cape Town and COO of the Desmond Tutu HIV Foundation. Linda's also the immediate past president of IAS and co-chair of the last AIDS conference. So
correct.
How are you finding the conference this year in comparison to when you ran the show? 2 years ago?
Well, I think, I think as everyone has said, the virtual experience is completely different. So I think it's tough to contrast them. It's a very different experience. I've actually been spending a lot of time worrying that I'm not on the right Zoom address, which was pretty much like I was always wondering whether I was going to the right room at the right time. So not a lot has changed in that respect, but yeah, I think the content of the conference has been as good as ever, and I guess that's, I'm proud of the field. We continue to innovate and do good science, and I think our theme this year was resilience, and I think we've lived the theme, so good on us.
Wonderful, fantastic. So for everyone listening on Facebook and on Twitter, do please get your questions across. My glamorous assistant, Matthew Hodson, if you'd like to pop up. Hi, Matthew, where's my cappuccino?
Yeah, I've got it for you. I don't know why you're not here.
Matthew is going to be monitoring questions. Is that right?
That is right. So if anyone has any questions, if you just post it below the tweet, which is on the aidsmap Twitter feed, or if you post it on Facebook, and I will do my darndest to get it to the panel, and then you can find out more. Get the answer to the questions that you're particularly wanting from the biggest stories from AIDS 2020.
Fantastic. Thank you very much. Okay, so if we could bring everyone on, please, but not Matthew because he's busy looking for questions. We're also hoping to have Dr. Anton Pozniak, President of the International AIDS Society and Chair of the conference. It's possible he may not be able to join us, but he hopes to, so be prepared for him to just leap on at any minute. But we've got lots of questions people have been sending over to me ahead of this. One of the issues that seems to have been coming up a lot in the conference is about weight gain. Laura, what do we know now that we didn't actually know before?
Oh, to be honest, not a lot more. So very brief background for people who don't know. Over the last 2 years, there's been a lot of focus on how HIV drugs might accelerate weight gain. Now, the reality is, on average, we all gain weight over time. Here in the UK, that's about 1/3 of a kilogram a year. In the US, not surprisingly, it's a bit more. And the two main types of drugs that have been implicated are TAF, which is the sort of new version of tenofovir that's been around for a few years, and also some of the integrase inhibitors. That's a group of drugs that's really the preferred choice in most guidelines now. And the newest drugs from that group, bictegravir and dolutegravir, which are very widely prescribed, have been shown to cause more weight gain. So when we say weight gain, what we're looking at is people in first-line trials, when they have not been on treatment before, gaining between 3 and 4 kilograms over 2 years. What we've learned at this conference is that that weight might settle down and plateau or flatten out, or it might not. There's two studies that really showed that. One was a study presented by Paddy Mallon, one of my colleagues, and he showed that in people switching old tenofovir to new, they gained quite a lot of weight in the first 9 months and then it settled down, but there's quite a clear step up. Then there was a study called ADVANCE, which has been discussed a lot, and unlike many of the studies we see in HIV treatment, ADVANCE was done 60% of the population were women, and often these trials are mainly men, and almost every participant was black, and many of the trials we see are in mainly white individuals. What that showed was much more weight gain, but quite concerningly, although it wasn't the complete set of data, they showed that weight gain continues between year 2 and 3. So just to put it in context, on one of the combinations most associated with weight gain in women, they've gained 8 kilos after 2 years on the treatment, and then another 4 kilos between year 2 and 3. So that's what we've learned really, is that there is a clear step up, new tenofovir, these integrase drugs, but it may not level out in all people.
Right. Oh, okay. And Linda-Gail, what are you seeing with weight gain in your region?
So Laura's already mentioned there these two kinds of tenofovir, the old one and then the new kind called TAF. So we don't yet have access to TAF. So our single regimen drug pill is made up of tenofovir, the lamivudine and dolutegravir. And there is a theory that the old tenofovir may, to a certain extent, have a kind of leveling out of the effect of the dolutegravir. So that may be a saving grace for us. That said, we are seeing weight gain. Not all of, I represent South Africa, not all of us have changed to dolutegravir. We were poised to make the move and then COVID hit. And so that's delayed our move a little bit because we had to give people multi-month dispensation. And so it's held things back. So we, I think it's a space we have to watch. We are a heavy nation to begin with, particularly the women of our nation are on the heavy side. But interesting, and I think this is the important thing, is what does that weight mean? Because when we ask these young women, many of whom have gained some weight, they actually are not complaining. So, if for different folk, it may mean different things. And I think we have to see what the metabolic impacts are. There was one other important study came out of Advance that said pregnant women who gain weight may have less favorable outcomes for their pregnancy. So we have to bear that in mind as well.
Right. Okay. Thank you. And Lucy, women do seem to be most badly affected by weight gain, but represent only a small amount of participants in clinical trials. What do you think we need to do to address that?
I just heard Linda mentioning DTG, and one of the reasons why we're being told DTG we are being denied DTG was because one of the issues would be to gain weight. As you can see, I don't know if you look at my photos outside here, you can see I'm big. I'm not a small young woman. I'm big-bodied, and I don't know if I have gained weight since I was put on DTG a year ago. I don't know. But I don't think it should be one consideration to deny someone a certain drug. And that said, we really just have to use common sense. We can't be saying we don't have women in trials and not doing something about it. We know we need to have women in trials. That is just common sense. Let us just use common sense. That is it from me, I think.
Yeah, absolutely. And one big story from the conference that everyone seems to be asking about is a potential cure story to suggest that we're a little bit closer to finding a cure. And Gus, you interviewed Dr. Andrea Savarino, who was on the study. What do we actually know about what's happened?
Well, it's so difficult to keep a sort of balance of sort of skepticism and hope with a story like this, because it's just one guy out of a group of 5. And this always seems to happen in sort of cures and things like that, is that one responds, and there's one monkey that responds to the vaccine, the others don't. But in this particular case, I couldn't sort of resist feeling a little prickle of hope when I first read the abstract on this. And the reason is because they didn't have to put this guy through any kind of extraordinary medical procedures in order to produce a situation where his HIV DNA, which is the stuff that's actually inside your cells, vanished, where his antibodies to HIV started going down to very, very low, which indicates there's no HIV around to excite his immune system. And they tried to grow HIV out of his cells and they couldn't. but we know that it takes several years trying to find HIV in the well-hidden places in people's bodies before we can really say this person has no HIV in their system. The exciting bit was that they used a simple regimen of drugs that are available today, and the extra drug they used was something you buy over a pharmacy counter, vitamin B3. So this is extraordinary. I mean, the skeptic in me is sort of, you know, I think, well, you know, in a year's time they'll discover HIV in him and he'll just be one of these people who's very good at controlling it. But then about 40% of me thinks this could be it, and so we need to keep tabs on this case. There's a lot we don't know, and there's a lot of research they were hoping to do that was interrupted by COVID, but I think it's potentially exciting.
What do you reckon, Laura?
Well, just no, I agree with Gus, but I think what worried me is that case was from a study that had 30 people in it, and there was no mention what happened to the other 30. Now, I'm sure they were fine. Presumably, they didn't stop their treatment. Gus is right, vitamin B3 is widely available and it's probably pretty harmless. One word of caution though, I was reading about it, and high doses of this vitamin can cause some sort of changes in your cells that you also see with aging. Now, I don't want to frighten anyone who's taking it. It's much higher doses than you get in a standard multivitamin and mineral supplement. And it's important to point out. So don't start taking 20 multivitamins to try and get that level. But I'd be really interested to know what happened to everyone else in that study, because they didn't explain that. Just talked about him. Do you know, Gus?
Yes, we did ask Andrea Savarino about this, and I read more about it. Yeah, they did put other people on treatment interruptions as well, and they all basically rebounded and got put back on art. They tried several different experimental drugs, including this one with gold in it that they used for rheumatoid arthritis. That didn't work. They tried a therapeutic vaccine that didn't work, but they don't know what's worked in the case of this guy. It may just be that there's something innate in him which is enabled to control the virus, and it may just be encouraged by this. But we, you know, so sometimes these turn out to be false alarms, but equally there is, you know, we've had a few where people said, oh, this is never going to work, and it's turned out to work. I think one of the classic examples was the RV144 vaccine study, where everyone said, oh, that's not going to work, but it did work a little bit. And as Linda will know, it stimulated a huge bunch of vaccine science. So even if he turns out not to have been cured, if something interesting has happened to him with this regimen, then that will itself be a kind of contribute to cure science, I think.
We just had a question over from Joe Josh, who asks whether the panel think that the cured guy is just one of the people who can have a break from medication for a year or longer with no viral rebound. What do you reckon?
Well, you know, my response to that would be, we know that there's a dance, if you like, between the treatments we give people and their immune responses. So it isn't all just on the side of the biomedical intervention. And that is what the cure, a lot of the cure regimens are trying to do, that through the kick and kill, or the, you know, they often use a vaccine to try and stimulate an immune system to also keep the virus down, if you're doing some other medical intervention. And so, it's, you know, I think Gus is right. And it's a shame that COVID came along, because I'm sure they had a series of immunological studies they wanted to do in this guy. And hopefully the specimens are all stored to be able to see what actually happened in a serial longitudinal fashion, because I think we want to know what's happened in his immune response that has somehow kept this under control. So I agree with Josh. I think that could well be a, you know, part of the story.
And Lucy, as someone living with HIV, I mean, how do you feel about this particular cure story?
It's very exciting, to be honest. I tell you, treatment fatigue is real. And keeping up. I've only been on it for what now? For 7 years, and I'm at some point I'm like, when is the long-acting injectable coming? But now, if there was a cure, now you can imagine this would mean so much for me as a person living with HIV, but for all of us living with HIV all over the world. So if it is really working, more attention should be put onto this.
Yeah, absolutely. And just going back to long-lasting injectables, when are we going to see that? I heard something about it being available in Canada very soon. Is that right? Anywhere else?
Not that I've heard of yet. I think there was some delay in the US application, but possibly Linda or Laura knows more about this.
Yeah, my understanding is there was a hold up on, there was nothing wrong with the drug, but something to do with what the FDA needed in terms of the dossier, and the companies were scrambling to get that in. But I think we're preparing for introduction. I worry that in the South, Lucy, we may have to wait a little bit longer. But hopefully they'll be coming soon, and I know I hear from everyone the excitement for the long-acting injectables.
And I think in Europe, I think the sort of approval is expected towards the end of this year. That means another probably 12 months before it's available in England. So I think England's going to be end of 2021. So yeah.
Okay, so fingers crossed. It's going to be.
Well, COVID has an impact, because the group I'm passionate about, the adolescents, the MOCA study has had to go on pause, which is the study that's telling us the dose we should use for people under the age of 18, under the weight ban. And so we're going to wait a little bit longer for the adolescents data and the adolescent approval, which, we can't wait.
And that is the group that needs the long injectable most, because we're having issues up to date with adolescents' appearance.
But I think for me, the fact that the injectable trials ran into so much difficulty because of COVID is the kind of shows you what one of the main issues is that you still need to, at the moment, to go into clinics. And obviously, hopefully when it's rolled out, the injections will be available in more settings in the community. But I think everyone accepts this is a huge advance. It's very exciting. But going forward, people want longer, long-acting, every 6 months, every year, implants that last even longer. So this is just one step on that journey, but it still remains an exciting development, of course.
Sure. And what are you hearing about the impact of COVID on HIV services worldwide? What's happening in your region, Linda?
Yeah, we're worried, Susan. I think I think it'll take a while for the real data to come out the other side. There's been some great presentations during this week, and the WHO obviously released some data. UNAIDS have it in their 2020 report. We have some immediate readouts, like how much testing has been reduced, how many diagnostics in terms of viral load measurements have gone down. So there's no doubt that services have been used less. And of course, there's a worry about stockouts. 24 countries have put up a worry flag that their ARV stocks are running low. So that partly, I think, is because we did multi-month dispensing. So we gave out more at the beginning of lockdowns. But also, I think because of the travel restrictions, drugs aren't coming into country. So all of this, I think, raises anxiety levels. And I think we're just going to have to watch this really carefully. Again, though, the positive side was we saw some fantastic operational innovation of what people have done when they needed to make sure that antiretroviral and TB services were not interrupted. So, I think, again, it shows that we can innovate when we need to, which I hope will carry outside of COVID, and say, how do we make these things more amenable and more available to more people around the world, regardless,
And what are you finding in the UK, Laura?
So we weren't hit as hard as we feared initially. I think it's fair to say, that there was a lot of contingency planning. HIV was prioritised from the beginning, so it's considered a core service. So we did things very differently. Most clinics switched to telephone, have deferred blood tests. And really, I don't think we're going to know until we come out of this what the pros and cons have been. I think people have been very happy in general when we've spoken to our patients on the phone. They don't want to come to clinics with blood tests. We've been able to maintain drug supply, and we're lucky that we've had enough staff to be able to contact people and still maintain urgent access. But I think what's acceptable now might not be in the future, and you know, I think we really need to, and I think it's given, I mean, the NHS the kick up the backside that it needed to innovate and introduce video technology and the like. But hopefully we will pause at the end of this, use our new technology and new ways of doing things. But we've got a blank slate, really, and I'm quite excited about how we can develop services and make it even more fit for purpose. I think we do a great job already, but I think we could do an even better job, and this will be the kick that we need to innovate.
Right, wonderful. And what are you finding, Lucy, in Kenya?
I think for us, other than the health aspect of it, where there's a shortage of drugs and dispensing is becoming shorter and shorter. At first it was at 3 months, now it's at a month. At some facilities it's even 2 weeks dispensing of drugs. And most women who are not on DTG already were not transitioned. So other than the health aspect of that and the fear that there won't be enough medication, there'll be stockouts, is the social aspect of it, where you find more and more people going through, how do I term this? You know, going hungry, facing hunger, facing losing their homes because they cannot afford rent. You know, social issues that are key for a person's appearance, like just having a meal or 3 meals to enable you to take your drugs well, or for mothers to enable to have food enough for their children and for themselves, for them to be able to take drugs. They're just social issues that even if you try solving, you can only do so much. They're more structural than anything else. Yeah.
Yeah, that's really worrying. Gus, have you had any virtual appointments?
Well,
what's your experience?
But actually, I've got my first virtual clinic appointment tomorrow. It just popped up. I mean, I'm completely stable on a couple of very powerful drugs, dolutegravir, darunavir, good stuff. So I'm only on 6 monthly appointments here. But you know, I'm not particularly happy about this. I mean, you know, they'll phone me up, they'll post me my drugs, but I want to know how I'm doing. So yes, I will not be happy not to have tests over a long period of time, even though every time I go, my doctor Mike Yule said, look, it's all in green, nothing wrong with you. Come back in 6 months. So that's great. But, you know, none of us can bank on that for forever. So I am really concerned about COVID impacting on the health of people with HIV. And like Lucy, I have seen surveys. There's been a really interesting UNAIDS survey, I don't think we've written it up yet, of gay men around the world. And a lot of them have lost jobs. A lot of gay men work in things like, you know, the leisure industry, hospitality, and 26% have had experience of having their antiretrovirals interrupted at least once because of the COVID epidemic. So it is of concern. One of my big concerns is that some of the progress we have made in HIV might go into reverse because of COVID.
Yeah.
Okay.
Oh, sorry. I was just going to say, just from a sort of local view again, UK CAB, so big UK community organisation, did a survey of people living with HIV. And one thing that struck me was 1 in 10 people would not be comfortable to speak to their HIV clinic in their own home on the phone. And the assumption that people want to, and that it's more convenient. And actually, and again, maybe going forwards, it's about not necessarily having those calls at home, but in a sort of community hub or something like that.
Yeah.
But again, the assumption that everyone wants to speak at home. And I agree with Gus. I think making sure people are well, and the things we've been really concerned about are, of course, people's mental health during this time, social issues, domestic violence, screening for non-HIV issues, blood pressure and the like. You know, that a lot of that's going to have been missed. So it's really important to stay aware.
Thank you. I think we're getting some questions, more questions coming through. Can I bring Matthew on? Hi,
Hello.
Matthew. Hi. So what are we hearing from our viewers?
Well, there's a lot of interest in the questions around weight gain. The Sophia Forum asking, well, they say, given that weight gain can occur in menopausal age, what other treatment options are there for women who don't want to have to deal with more weight gain to ensure good bone health if we are to exclude TAF? And also wanted to ask Laura in particular whether she could speak to any evidence in the UK around women taking Biktarvy and reporting of weight gain. So I think that one's obviously getting people very fired up. There's also a question from Wade Shearer, and he wants to know from the panel what their views are with regards to people with HIV signing up for the Oxford COVID-19, that's the CHAD-OX1 vaccine trial in South Africa. Okay. And there's another question. Do you want another one?
Yeah, give me another one.
Yeah, well, come on. Well, this is one I'm hearing a lot. So, and I know that Laura has written about this, so I'm sure she'll be eager to answer it. And it's the question: can HIV drugs treat or prevent COVID-19?
Okay, thank you, Matthew. So if we bring everyone back on, Laura, can HIV drugs treat and cure COVID-19?
No. So I think obviously, like pretty much every time a new outbreak emerges, there's a series of drugs that are always tested, and that includes hydroxychloroquine, includes some of the older HIV drugs, and certainly lopinavir, ritonavir, one of the older HIV drugs, has been shown in a recent trial performed in the UK that it definitely doesn't help. Didn't cause more harm, but it didn't result in any benefit. The debate has been around tenofovir, actually, again, coming back to that drug, about whether that's protective. So in Spain, for example, they've shown that people on tenofovir were less likely to get sick with COVID than people who weren't. Therefore, it might be protective. But people on tenofovir were more likely to be well. So if you've got kidney disease, for example, which we know is one of the things that increases your risk of dying from COVID, if you've got kidney disease, you're not going to be on that old version of tenofovir necessarily. So it's always hard to really tease out. And for me, the thing that makes that unlikely is nobody has demonstrated in the test tube that tenofovir works against that virus. There's modelling, structural, clever, computational, God knows what studies, but no one has shown, stick it in a test tube, it doesn't kill that virus. So I think the answer is probably not. Of course, it's important to test these things. But right now, I think there's quite a lot of lopinavir left over in the UK that isn't going to be used in the trial.
Right. Okay. And also in terms of the question about Oxford, Laura?
Yeah, so I think that was, well,
Linda, yeah.
So I think that they're testing it in the UK, Laura. What are you finding there?
So also, certainly to my knowledge, I can't say I've checked very recently, but all the vaccine studies have excluded people living with HIV.
That's what I wanted to find out, because I was genuinely thinking of applying, but I didn't know.
And so I'm taking part in one of the vaccine studies. And the reason they do that is because they're worried about anyone with any difference in their immune system being in those trials. Now, I don't think that's right. I think the key thing is, if you have HIV, is that vaccine safe? And we know for non-live vaccines, even for live vaccines, things like yellow fever, as long as you've got a good CD4 count, that vaccine is still safe for you. If the vaccine's safe, in my opinion, there is no reason for people with HIV not to be included in those studies. I think it's so it's some of it's historical, but I think we need to make sure we call for people with HIV to be included.
I mean, and one thing that I get asked a lot is, are people living with HIV at greater risk from COVID? I mean, has there been any? I think there was some data from South Africa recently, Linda. Is that the case?
Yes, so Susan, I was actually going to say it's a little bit of evidence against tenofovir as well. So that study that you're referring to was conducted in looking at health records in Cape Town, a great number, many hundreds of thousands of health records, and then looking at our HIV population. And what they showed was what we're seeing around the world, is that COVID disease occurs in people who have other diseases, particularly diabetes is coming up very strongly, hypertension to an extent, older people with these comorbid conditions. HIV does cause an increased rate of death with COVID, but it's not large. It's a minimal amount compared to, say, diabetes or hypertension. What was interesting from our data is it didn't matter whether those people were virally suppressed or not, and you would imagine the people who are not virally suppressed may be less exposed to antivirals, and we didn't see a difference. Now, the good news is that we don't have that many people in the Western Cape who are not virally suppressed, who are HIV positive. So that may be a confounder, you know, in that data. But yes, we saw up to twice as many people for age, when you adjusted for age, seem to have become sick and die of COVID.
Yeah.
So, and even in those individuals, comorbidities played a role. So I think, you know, that's the story. So I think we were very worried at the beginning, particularly, I think Lucy will bear out, you know, as we sort of watched this pandemic moving across the north, we were very anxious, you know, in South and Eastern Africa about what it would mean for us. And, you know, I think we're relieved it doesn't seem to have as much impact as what we had really worried about.
Has that been a concern for you and people that you work with, Lucy?
Yes, it has. And I was just thinking how mental health issues have skyrocketed as well. I myself, I just had to start seeing someone, although this is not really affordable, since I'm not on health insurance. You find that it's an issue. And also I saw today that even with COVID, if you go to a hospital and you're suspected of having COVID, the health insurance companies jump at that facility, and they say they can't cater for that. Can you imagine? You think you're safe because you have health insurance, but then you're not. And the other issues that I saw that were really saddening was how we had to pay for our own quarantine. If you went on quarantine, you had to pay for it, and it's not cheap. And people have lost jobs, or people are not going to work if they're in quarantine, and they're expected to just cough out of nowhere $280. It's just a scary time for sure, because you're still not in the light. We can't say we are now at a place where we are feeling safe. Our country, the borders just opened. School has been postponed for the whole year of 2020. Everyone will have to go back to the class that they were in. Just different weird things.
Oh, that's so awful. One study that concerned me, that I know it was quite a small one, but there was a study from King's College Hospital in London that seemed to suggest that Black people living with HIV had worse outcomes from COVID. Is that something that anyone's seen? Or Gus, can you talk about that study at all?
Well, I mean, in the UK, it's absolutely, completely the case that not just Black people, but also people of Asian background have been much more vulnerable to COVID. But I think that's for socio-economic reasons. I don't think there's anything necessarily sort of about them physically that's different. I think it's much more that Black and ethnic minority people are much more likely to work in public service jobs. They're more likely to live in multi-occupancy housing. They're more likely to have to work when other people can do it from home. All sorts of things, all sorts of factors go into this. And this is a pattern that's seen worldwide. It's certainly been the case in the States, as you may know. And I was just reading a really interesting study from New York, which found really that the prevalence of antibodies in people was absolutely tied to the relative poverty and the crowdedness of the neighborhood. So I think it's all about that stuff.
Are we finding that COVID?
Sorry.
Yeah, go ahead, Lucy.
Something has mentioned. There was an article from Cambridge. I don't remember it in full, but they were saying people with different blood types tend to be more affected. I don't know if those studies are happening or it was just an assumption. Like they were saying, people with O blood group are less likely to get COVID compared to people with blood group type A. Oh my God, yeah, you get what I'm saying.
Linda or Laura?
Oh, I don't know about that. I know I'm Group O, but I don't know about any association. But just coming back to the point, and Linda talked about the Western Cape data. There was a very interim initial analysis of deaths in the UK presented at the British HIV Association conference last week. And there was also an association between higher risk of death, although again small and nowhere near as big as, for example, having a high blood pressure or diabetes. But it's a signal again that we need to explore, but the numbers are fairly small at the moment, so I wouldn't draw too much from it.
Okay, fantastic.
Yeah,
and I think,
not to belabor this point, but I think, Lucy, people are looking for all kinds of associations. So aside the blood group, I think vitamin D is another interesting one that is, I think still hasn't completely landed. I think the jury is still out there, but that's fascinating epidemiological association again, that countries where they fortify vitamin D are looking very different to countries where they don't. So, vitamin D is, for the infectious disease world, has been an interesting molecule for a long time. So, I think we still have a lot to learn, and we will.
Absolutely. I know that Matthew also flagged a question about weight gain from the Sophia Forum. Is that right? Do you remember that question, Laura?
Yeah,
I remember that question. It was about postmenopausal women who don't want to go back on TDF because they might have osteoporosis or whatever.
Yeah, so I think, the answer there is we've got the 2 drug options now, and I think that's something that's really been established over the last couple of years, is that if it's the right drugs, 2 are as good as 3. And if you take 2, then you don't need to worry about old tenofovir or new tenofovir or some of the other drugs that might not be ideal as you get older. You can take a combination of just 2 medications instead.
I did want to say there, though, that I think it is, I know, and I'm one of them, that I've worried about the middle age spread, but actually this is a protective factor for us as we get older. Being slightly on the plumpish side is good for our bones. It is not good for us to be skinny and drinking coffee all day and not exercising. So I do think we're going to have to look at the client, at the patient, and it's a patient-centered approach. Is it the weight gain that person needs to worry about, or the bone health? And weighing up our options per participant, per patient, I think is the way to go. So just, it's not necessarily going to be one recipe for all. Okay,
brilliant, thank you. An issue that that's come up in the conference that I think I like to pose to you, Gus, is a study that's shown that PrEP prevented 3/4 of HIV infections in a large African study. Were you surprised that the impact was so great?
In fact, there's been 2 studies which show a really sort of disproportionately large effect of PrEP in women in Africa. The other was the ECHO study. I just wrote it up yesterday, which was specific to South Africa because they only looked at the South African sites. I think one thing I want to say is about the injectables. We were talking about the injectables as treatment. Of course, one of the things that came out at the conference was very positive results that we've already knew about from March of injectables as PrEP. But, in terms of licensing, that's probably a year behind the treatments, I would say. But these were not studies that intended to look at PrEP. One was a very, very big 2-country study of just general health improvements and seeing if it reduced HIV incidence surge, and the other was a smaller but still quite big study of whether contraceptives in women or certain kinds of contraceptives increased liability to HIV, and they both introduced PrEP halfway through, and they found extraordinary drops. In one case, 74% drop in HIV incidence in the women who were given PrEP. In the other, a 50% drop across the whole study, regardless of whether women took PrEP or not. So I should say in search, that was women and men. But it was women that saw the big drop. And this seems disproportionate to the actual proportion of people who were put on PrEP, which was much smaller than that. So what this is saying to me, and one of the exciting things I find about PrEP, is that the right people end up taking it. Maybe not everyone takes it. Maybe some people only take it for a month. Maybe some people take it for a few months and then stop and then start again. But that people seem to have a fairly good idea if they're given basic information of when they're at risk, and PrEP seems to work almost better than you might expect. And I find that very exciting.
Fantastic. And
yeah,
yep, go ahead.
So Gus, I was going to say we're now calling that, I mean, to coin jargon, effective prevention, and I think it's an important, because it gets us away from adherence. Because we know adherence, we want people to take the pills we prescribe in the way we prescribe them all the time. But in effective prevention, we're saying people will figure out to take it when they're exposed, when they're at risk of HIV. And that is, for me, a huge win for PrEP.
Mm-hmm. Do you think we're doing enough to make PrEP available to women?
I think there's been a lot of news on PrEP and women at this conference, and I think that's what was kind of needed to persuade both the sort of the healthcare establishment and also women at risk of HIV themselves that this might be an option for them. I think up till now we haven't had enough information, and if I was a woman sort of at risk of HIV, I wouldn't be sure about PrEP. But if I'd read some of the info from this conference, then I might be changing my mind. So I think the history of PrEP has always been that it's sort of the few early adopters and then suddenly there's an acceleration. And I think this is what we might see, hopefully we'll see. But it all depends on supply as well.
Lucy, how important do you think PrEP can be for women?
I think it's an important part of prevention, because when you think of prevention, I always ask people, are you sure that prevention is all about condoms? And condoms is in terms of male condoms, not even female condoms being readily available. So I'm happy to hear that more women are taking PrEP. I've not had much interest in this area. And I'm happy to hear that more women. I don't know about the availability. I can't tell you if a person was to ask me where to go and take PrEP now, other than the government facilities, I wouldn't know where to tell them to go and get it readily. And I know there are processes and procedures for you to be given PrEP. You have to show proof of risk or something like that. So the barrier could be where you're going to access PrEP. The one who you think has the information might not have, and that could be also a barrier.
Yeah, one warning flag was a little study from Lesotho, which was one of the countries surveyed, and they asked young women who discontinued PrEP, why did you stop? And the biggest single reason was an unfortunate interaction with the healthcare provider. They knew it worked, they accepted that it worked, they weren't worried about it. It was the attitudes of the doctors that put them off, I'm afraid to say.
No, absolutely. Lucy, a question that's come through is about intimate partner violence. Obviously, women living with HIV are at increased risk, and the risk seems worse during the COVID crisis. What advice could you give a woman who may be in lockdown with an abuser?
That's really a difficult question, I must say. We are at a place where the cases of gender-based violence and more so intimate violence in our country, and I think in many countries in our region, the cases are more than COVID cases of gender-based violence, and especially femicide. I don't know what's up. We really don't understand what is happening, because the cases of femicide are at an all-time high. And I would just tell you, I'm happy that the restrictions are relaxing a bit. If you're a woman facing violence, living with an abuser, if you can go, please just leave. And there are places where you can get help. There are women organizations that you can approach. Just don't stay silent and stay with this abuser hoping that they will change, or hoping that anyone is coming. We won't know if you won't reach out, and we won't come in to help if you don't reach out. So the key thing for me is reach out to people you trust. I know the people who we expect to help us, the police or the government might be reluctant on this. I think they just don't know what to do with gender-based violence or intimate partner violence. I've not heard once the president mentioning anything on this agenda, and it's an issue. It's every day on the news. It's on the newspapers, but somehow that doesn't seem to get into his speeches, you know. So there are people who are willing to help you. So reach out to people who can help.
Absolutely.
And then just to add a couple of sort of specific things in the UK. I mean, you know, we know that domestic abuse has increased during the lockdown, but certainly HIV and sexual health clinics routinely ask about domestic abuse, and certainly it's a question that we've been endeavouring to ask in all of our phone consultations. And it's a difficult question to ask, but overwhelmingly, I've had so many people, and people I've known for years, and I know their partners, and I still ask the question, and they thank me for asking. But I think you're right, you need to tell somebody to get away. And there's two specific which people may know about in the UK, but from a mobile phone, you can dial 999 and stay silent, and you just press 55. That gets you through to your local police force, who will then ask questions with only yes and no answers. And the other, the organisation that's really foremost on the 24/7 helpline is called Refuge. And actually Refuge have one of those things on your mobile phone or computer where you can minimise the window very quickly. So if someone walks in or tries to look over your shoulder, you can hide it. Now I know that that's obviously very UK specific, but there are examples of trying to make what is very difficult and hopefully a little easier to sort of get that help if you need it.
And how about in South Africa, Linda?
Well, I would agree with Lucy that this is our greatest epidemic, actually, one of violence, and it's intimate partner, it's gender based, and it's men on men. You know, I mean, it's violence it has exploded, and of course, economic stress just compounds that manyfold. So you know, I think it's been this tension of lockdowns to try and flatten curves, and then all the stress and difficulty of the economic impact alongside the economic recession. I think, you know, we have our work cut out, that all of that, these are drivers for HIV as well. We know that. So, you know, a lot to be done. And the word I'd like to put out there to funders, if any of them are listening, is we have to keep these CBOs and NGOs going through these kinds of times, because often this is the only thing that young women or people in general can turn to. But again, unfortunately, these are the very organizations that, you know, go out of business during tough financial times. So just very important for us to keep bringing that home, I think.
Thank you. I'll go back to bring Matthew on for a moment. Matthew, have we got any other questions coming from the audience?
Yeah, we've just had a question in from Nick Freeman. He wants to know how safe 2 drug regimens are.
And have you got another question?
Oh, another one. You don't like that one? Okay. Well, the other question which I had was people wanted to know what impact COVID has had on PrEP use and sexual behaviour.
Okay, wonderful. I think I can remember both of those this time.
Go for it.
Thank you. Thank you. Laura.
Susan.
Two drugs.
2 drugs. So how safe are 2 drug regimens? I mean,
yes.
So safe in terms of, are the drugs themselves safe? Yeah, they're safe in 2 drug regimens as they are in 3. And the drugs that we're really using for 2 drug regimens now are based on dolutegravir, and that's a drug we've spoken about already. It is associated with weight gain, maybe less weight gain in 2 drug regimens than 3, possibly. But is giving just too safe in terms of keeping viral load undetectable? And the answer absolutely is yes. Compared head to head, as long as you don't have resistance to those drugs, then 2 are just as effective as 3. And we've seen that now out to 2 years for first line. There's switch studies, and there's also a lot of real life use. So in clinical trials, people tend to take the pills very well and come to their visits, but there's also a lot of data showing in real life that using these 2 drug combinations is as good as 3.
Yeah, excellent, brilliant. And Gus, PrEP question?
I just want to say I'm on 2 drugs, darunavir, dolutegravir. So, you know, I gave up. I stopped taking tenofovir, which was the 3rd. I didn't need it, really. At least that's what my doctor decided. I agreed with him. It depends which 2 drugs. You wouldn't give Truvada to somebody, which is tenofovir. To treat their HIV. It wouldn't. But the new drugs, yes. Okay. The PrEP one, yes. There have been quite a few surveys. We've reported on some of them in Australia, in the US, in the UK, certainly about gay men. And the prevalence of hooking up has gone way down. Some guys have stopped their PrEP. In fact, I think a majority in the Australian and UK studies. But that doesn't mean that a minority are not still going out, hooking up and going to sex parties and things like that. And I know that, for instance, the Barcelona clinic has made a policy of actually kind of delivering PrEP to guys who they know are still carrying on with sex parties. But in fact, mostly what we've seen is a big decline in both sexual activity and, as far as we can see, the decline you would also expect in STIs as well. So we don't know how it's going to happen, what's going to happen in the long run. This is probably just a sort of temporary decrease in sexual activity, but that's what we've seen.
Okay, brilliant. Thank you. I know we've only got 4 more.
Stopping their PrEP, but you know, it's as long as you and as long as you sort of started to get in advance, a couple of doses, you should be okay. Okay, brilliant.
We've only got a few more minutes, so there's a few things I want to ask you about. The target 90 by 2020, we failed to achieve that. Linda, why do you think that is?
Well, I have heard it blamed on COVID. I think that's totally unfair. We've only had COVID for 6 months. We were way off track, unfortunately, in 2018 at the last big conference. We knew we were going to miss the target, actually. We put up the red flags. We have not done everything we should have done as quickly as we should have done it. And, the warning sounds have now gone off. And now, as soon as we can, I think we have to do everything we need to do at scale for everyone in a universal way as quickly as we can and try and get the train back on the track. I think that's the bottom line.
Okay, brilliant. And was it 690,000 people died from AIDS last year? I mean, that's absolutely outrageous considering the progress that we've made. And what needs to happen now?
Well, I think we have to stop making an excuse around COVID. I think it is not an excuse. I think we have to integrate, move, get alongside it, wrap around it, get with it, and move forward. So I'm a little impatient with the whole COVID thing. I think we have to really recognize that HIV is still particularly in my region, in my country, is a big problem. There are other regions world where it's out of control, and we have to get treatment to everybody who needs it. That's test and treat, and we have to get other programs to everybody who needs it, and that's all we have to do, and we have to do it quickly,
Absolutely. And I was really shocked by the number of children that are dying from HIV related conditions every year. I mean, what's in the pipeline in terms of pediatric medications?
I was just writing up about this. I think that there has been delays in pediatric medications, and certainly Linda would know more about it than me, but also children are surprisingly under-tested. There's lots of kids who have HIV, we don't even know they're there. And that's because if they don't get a positive test when they're a baby, then often the parents don't come back and test them later on. And there was a really interesting presentation on doing what they call index testing. You test somebody for HIV, they turn out to be positive, you go to their household, or you invite their household in, you test the partner, you test the kids, and they're finding lots of unsuspected HIV infections in children. But it is really bad. There's only something like 53% of the children in the world with HIV are on treatment, compared with 2/3 of the adults, and that's just, that's just
shocking. Right. So we're about to run out of time, but one very last question. For the next AIDS conference in 2 years' time, what would you like to see? We have a quick fire round. Starting with Laura.
I'll start.
Oh, thank you, Linda.
Okay. No. I was going to lead off with, sorry, Laura, I'm just going to lead off from what Gus has said. I think the fact that we have not eradicated mother to child is unbelievably slack of us as a community. And so I'd like us to see if we can finally eradicate vertical transmission of HIV around the world. It's within our grasp. We need that, that push, and we can do it.
Brilliant. Lucy?
I just hope we even go. It's a physical meeting, first of all, and we will be talking of having a vaccine having reached everyone, COVID vaccine, and hopefully the injectable to have rolled out, but closer to home.
Fantastic. Laura?
It was hard to follow those answers, but I think, yes, in real life, I think that we'll be celebrating the US rejoining the World Health Organization.
Yes.
Talking about the latest data for an implant.
Wonderful. Thank you. And finally, Gus.
Yes, I think injectable PrEP should be licensed by that time. And hopefully, Linda, if this is not sort of like, asking, tempting fate, we will have the results from the next big vaccine study, and we shall hope that that has positive results from the Imbokodo vaccine.
Okay, fantastic. Well, thank you all so much. We've run out of time. It's been an absolutely fantastic session. So I'd like to thank all of my amazing guests. I'd like to thank Matthew for being behind the scenes with the questions. I'd like to thank Disruptive Live for coping with all of the technical issues that we've had to deal with. Everyone who's listened and got their questions across. This has been a brilliant session. Thank you so much, and see you soon. Bye-bye.